Hey, good afternoon, everyone. We're going to wait another 30 seconds before we get started. Just want to give everyone an opportunity to log on for those that are trying to do so. Okay, good afternoon, everyone. I'm Mike Casamassa. I am the VP of Solutions for Henry Schein, and we feel very fortunate to be a platinum sponsor for today's webinar. And we really appreciate this opportunity from Florida ARM. We are always investing in education and really happy to be able to provide education on the remote patient monitoring landscape today. I'm going to share with you that we chose this subject because we feel like we have some really good expertise. We did about 5 years of due diligence in this space, and through the process, we were fortunate enough to find who we believe is the foremost thought expert in this space, Dr. Lucianne Ide, who is going to be the speaker today. She is the only current CEO and founder of an RPM company that is actually a clinician that we know of. She is an MD, PhD, physicist, geneticist, and just an all-around amazing person. But I will share with you that her superpower is taking incredibly complex and nuanced information like RPM and distilling it down into something that is highly consumable and also understandable, and most importantly, actionable. And that's our goal for today, is to not only provide you the education about remote patient monitoring, but give you some information that actually can turn into action and hopefully compel you to do something. We believe that RPM is truly transformative technology, one of the most important technologies that you're going to see in the healthcare space, especially as it relates to chronic disease. And we're really fortunate, or feel fortunate, to be able to provide this education for you today. If you do have any questions, please put them in the chat and we will handle them at the end. And we look forward to hearing from you. Without further delay, I now want to introduce to you Dr. Lucianne Ide, who is the CEO and founder of Remedy. And thank you once again for attending.
All right, thank you, Michael, for the introduction, and thanks to all of you for joining today. Next slide, please. So on the webinar today, we'll be covering a couple of different topics. We'll start with some of the challenges in today's healthcare landscape that really set the stage for why remote patient monitoring is an important technology that can have clinical benefits and operational and financial benefits to organizations, whether those organizations are currently in a fee-for-service construct or value-based or somewhere in the middle, as well as how it affects your patient's experience of care. And then we'll sort of wrap up, covering that field of different aspects of RPM and considerations that we see health systems debating as they consider implementing remote patient monitoring programs and technologies within their practice. Next slide. So, if we can all flash back for a minute to the major healthcare problems that were the focus before the pandemic, many of them are still the focus coming out of the pandemic. Chronic disease, the prevalence of it and the need that individuals living with chronic disease have for a more continuous model of care and support, not just when they're in the clinic, but between those clinic visits. And we all saw the impact of poorly managed chronic health conditions during the pandemic on people who were affected by COVID. Parallel to that, we have the challenge of information overload and burnout on our clinicians. And part of that has to do with their electronic medical record and the amount of information that's available to them, but how cumbersome and difficult that can be to access at times, and how that sort of in an additive way, can add minutes and hours to their work week as they, struggle to document and find information. So being really aware that as new technologies are introduced to organizations, that the impact on workflow and on the clinical clinicians and clinical staff is really well considered. And then third is that staffing shortage. And, we were aware of this, but again, it's been accentuated that not only is there a primary care shortage, there's a nursing shortage, there's an IT shortage within health systems. And so, we really are having to think about how to help everybody practice at the top of license, how, healthcare, is really a team sport with everyone playing their role in a collaborative way. And that is true as you think about remote patient monitoring solutions as well. Next slide. So during the pandemic, there was a really aggressive adoption of telehealth, which I'm sure all of you experienced, both as professionals and in your personal life, as well as a lot of different point solutions trying to address either, access to care challenges due to the pandemic, staffing shortage challenges, revenue shortage challenges, and continuing operations. And what that resulted in from the IT team's point of view, as well as clinicians who were the ones using many of these solutions, was being even more overwhelmed by a variety of point solutions and new programs. And so we see a lot of health systems trying to take a step back and say, okay, we did all of that. And, it was amazing how quickly technology was put in place and adopted. Now, what does this look like going forward from an enterprise approach, a strategic approach, a long-term scalable and sustainable approach? How do we bring some of these things under the same umbrella? Maybe, find solutions that meet multiple needs, not simple individual needs. So we hear that from a lot of organizations today. Next slide. And then I think the last category of challenges is where people are in the continuum of payment models. And, are you in a fee-for-service model? Are you in a value-based care model? Almost everybody has a foot in each canoe today. And I'll talk about in a minute sort of some of the stepping stones that CMS is trying to provide, I think, to help people get from fee-for-service primarily to this future state, when in 2030, CMS has said that they want all Medicare beneficiaries enrolled in some sort of accountable care program. Well, they need to provide the support and the mechanism to build the staffing models, build the experience to get there, because everybody's straddling this discomfort. So if you look at sort of introduction of the Accountable Care Act in 2010 and moving towards a future state in 2030 with, mostly risk-based contracts in Medicare and Medicaid, one thing that has been really, well done and I think well adopted is the introduction of some of these payment models that basically pay for proactive disease management type activities. And I know my works with organizations who are fully capitated and fully fee-for-service, and the capitated organizations, know very well health management in order to achieve the outcomes and, cost metrics that they're shooting for. But when we, had ACA in 2010, it was really sort of a bridge too far for groups who didn't have that, experience and often decades of experience. And so CMS introduced a series of codes. First, the Chronic Care Management Program in 2015, where, practices are paid to, actively manage a care plan of patients with 2 or more chronic health conditions, and they're paid for that activity. And then in 2019, remote physiologic monitoring was first introduced, and CMS iterated on it for a couple of years, but they're basically paying for the activity of continuously monitoring a patient population, and they only need one chronic health condition through physiologic data. And I think they did a really nice job, and we'll talk a bit more about that construct later, of recognizing the work that goes into it and fairly reimbursing the practices for the work that they need to do. And then last year, they followed suit with expanding to something called remote therapeutic monitoring. Very similar concept to RPM, but it doesn't have to be physiologic data. It can be medication adherence data and some, complementary data sets for specific conditions in the respiratory or musculoskeletal space or behavioral health they added this year. So overall, though, we think it's a pattern of, again, how CMS is trying to help practices bridge to a value-based care model by paying them fee-for-service for sort of value-based activities. Next slide. And so people can mean, as you hear about RPM in the marketplace, people mean a lot of different things when they use these terms. And we thought it would be helpful for this educational session to really, highlight some key components and differences in what people might be referring to when they talk about remote patient monitoring or remote physiologic monitoring. So RPM falls under the general category of telehealth. And meaning it's one modality for helping to provide care to patients outside of the traditional clinic-based setting. And in this case, focusing on connected digital medical devices. So glucometers, blood pressure cuffs, scales, pulse oximeter, etc. Under that, generally, folks have one of two things in mind. One is RPM for chronic disease management. So that's that longitudinal care plan of my patient who has poorly controlled hypertension. And I enroll them into an RPM program with the goal of improving their hypertension control and across the population, improving my practice's hypertension, outcomes. And, as a byproduct, if we do that successfully, we can point to cost reduction, avoidance of, acute care like ER visits, urgent care visits, inpatient admissions, as well as an increase in patient engagement in their own care. And we have some, really good data to back that up across the industry. These devices tend to be pretty straightforward medical devices, like I mentioned, blood pressure cuffs, blood glucose meters, CGM, scales, etc. And this is an ongoing program. So sometimes we'll get asked, how long should a patient be in an RPM program? And again, it depends on the healthcare delivery system, their patient population. Sometimes clinics will enroll patients in this, get them to goal, and then kind of put them on a maintenance plan and discharge them so they can open up capacity to manage additional patients. Other institutions may, enroll patients in these programs and then, continue some form of monitoring for as long as the patient wants to participate. So that sort of summarizes RPM for chronic disease management. Next to that, you have, RPM for post-discharge monitoring. And this is where you're sort of bridging from RPM to, hospital at home. And there's this little, niche of, putting together a remote monitoring program specifically around post-discharge management and monitoring. And this often aligns to incentives that the system may have around preventing readmissions for particular disease states like heart failure, or, patient safety considerations of just, making sure that that patient who may not have easy access to return for follow-up appointments, that the clinic is able to follow up with them from the home. And again, we see, slightly different devices being used here sometimes versus in chronic condition remote patient monitoring, and these programs tend to be a shorter duration. So that could be anything from a 6-week postpartum program for women who had hypertensive complications of pregnancy to a post-discharge program for somebody who was admitted with either a diabetes or heart failure complication, was stabilized in the hospital, but they want to make sure that when they go home, they continue to progress and not end up back in the hospital. So next slide. So I mentioned that, in the fee-for-service world, CMS introduced this construct of billing codes first in 2019, and then they, took feedback and sort of iterated on these some over the following 2 to 3 years. So you basically have 4 codes that represent the reimbursement model for remote physiologic monitoring. You have a code that acknowledges the time of staff for onboarding a patient to the program. So that's the 99453. And that is, literally setting up the device, teaching the patient how to use it, and onboarding them to the program. And that is billed one time. Then you have the ongoing billing that can happen month on month. And there are 2 kinds of codes for that. There's 99454, which is really the data transmission code of you need 16 days out of the month when data is automatically transmitted from the patient's device to the clinic and the platform that they're using. And everybody can debate the 16 days and if that's, clinically valid or not, but it is what it is. That's what CMS has put in place. And it appears in the 2024 physician fee schedule that they're going to stick with that. And the practice gets reimbursed for, patients meeting that criteria of 16 days of readings per month. On average, these are national averages, $50. Then you have the time codes, which are 99457 and 99458. And these represent the time that's spent by the clinical staff monitoring the patient. So several questions we often get about this. It does not need to be a physician or other, qualified healthcare provider, meaning physician, PA, NP, et cetera. This can be done under the supervision of the healthcare provider. And so many groups have a nurse, a medical assistant, a pharmacist, a pharm tech, back to that team-based care concept. They will put together a team that's going to help manage this population of patients and sort of escalating, care as indicated. So, the primary team may be monitoring the dashboard of data, reviewing the patient's data, connecting with the patient. There's a requirement that once per billing cycle, there's a live interactive communication with the patient, meaning a phone call, a video visit, or if they happen to have an in-person visit that month, that counts. And then, as that team engages the patient, makes sure they know how to use their device, they understand their data, answers their questions, maybe about their medications, and also gets to count the time that, I'm spending, in the chart, reviewing the data, making notes about it. All of that time gets aggregated over the course of the month. And when you add it up, the codes pay for 20-minute increments of time. So the first 20 minutes is billed under 99457 and pays on average $49. If that patient is complex and more time is spent with them, then you may incur, additional segments under 99458 of time in 20-minute increments. So that's really the bones of an RPM program that is using the current reimbursement methods to support the program. Next slide. So if we look at a simple case study of what this looks like in a single physician practice, another question that's often brought up in this field is sort of what kind of engagement levels do you see with patients and adherence to the program? Because this is a program that you will enroll a patient in, consent them to be part of, and educate them about in that initial setup. So this is showing, just an example of a practice and their numbers around compliance to those two codes. So the pink code is the 99457, that's that time-based code, 20 minutes of time spent on that patient over the course of the month. And they're achieving that, 20 minutes for 99% of their patients in this practice. The blue bar is the 99454, which is the data transmission. So that means 72% of their patients were compliant with taking a reading 16 days out of the 30-day cycle. These two codes are billed independently. So 99457 can be billed even if they don't meet the threshold for 99454 or vice versa. And so then you see if you sort of, average this up for over 104 patients in the practice, the kind of, revenue that's going back to the practice to support this program. Next slide. So a couple of key takeaways around, groups who are putting in place remote monitoring programs and operating in a fee-for-service world. Number one is patient engagement. As you just saw in that example, it's the patient engagement that's driving the reimbursable activity, meaning if I enroll a patient in an RPM program who doesn't engage, they're not going to benefit. And, I'm also not going to get reimbursed for their participation in the program. So this can get into, how do you select patients? How do you describe the program to them at that time when you're, consenting them? And how do you drive the initial engagement? And all of those are really important in the program. The next really important component of patient engagement, it really ties back to that, is making this easy for patients. And what I mean by that is, the patient may be super excited about being part of this program, They may be reluctant because this is a problem that they have a hard time with. They have a hard time controlling their blood pressure or their blood glucose, but they know it'll benefit them, so they say yes, they want to be in the program. Well, if you send them home with a technology that's difficult to use and they're already kind of begrudgingly participating, you will quickly lose their engagement. So, what we mean by frictionless technologies are medical devices with connectivity built in. They can have cell chips in the device, in the blood pressure cuff or scale or glucometer. And so that patient just uses it like a scale or a blood pressure cuff. They don't have to worry about having internet at home, pairing it to their smartphone, pairing it to a hub, plugging something into the wall. The device just works. And when the device works for the patient, then the practice isn't getting tech support calls from patients and everybody's happy. And then the last piece, as we transition to sort of talking about the practice, is really thinking about the workflow implications. So who is that, team who's going to manage this program? And how does this fit into their other responsibilities? So, trying to make the workflow as efficient as possible. One way to approach that is integrating this technology into the electronic health record so that the data lives right there in the chart, in the EHR. There's no signing into a separate system or typing data into another system and sort of creating patients as you set them up. That is a big win of a time saver because it really comes down to the precious amount of time that the team in the clinic has and limiting the number of clicks that it takes them to offer this program to their patients and then follow up on the data as the data transmits back to them. Because the last thing that we need is to contribute to the clinician burnout phenomenon. Instead, we all collectively in the technology sector need to be focused on streamlining workflows, reducing clicks, bringing meaningful data and insights to the clinical team that they can use to help their patients. So those are a couple of key tactics for that. Next slide. All right. So that was, really looking at RPM through the lens of fee-for-service organizations. But as I mentioned, there are plenty of organizations that are either fully at risk and sort of fully capitated plans or have significant value-based contract motivations to use RPM as a tool to help them achieve those outcomes. And a couple of those outcomes that often align well to RPM programs. So things like star ratings and HEDIS measures, the comprehensive diabetes score, percent of a population with their hemoglobin A1C target, statin usage in patients. I know that that's not a remote monitoring program, but there's this interesting synergy between patients who are more engaged in their disease state and now feel more, self-efficacy around their ability to manage their diabetes or hypertension as examples. You'll see better medication adherence in other parts of their disease management, which is an interesting crossover. And then controlling high blood pressure is another measure that many organizations report on. So those are a couple of examples, but as your institution might be looking at RPM, really thinking about what is the intersection of quality measures, population health issues that you're committed to already that might have a really nice synergy with an RPM program that you're offering to your patients. Next slide. So along those lines, here's a little bit of data of what that, looks like for an organization as they track those outcomes. So you don't need to see all the small numbers on the graph, but this is an example of looking at a 6-month period of time of a cohort of patients who are in an RPM program. Nearly 50% of them get their A1C, under control, meaning in this case, and their quality measure below 8%. So starting at nobody who's enrolled in the program, that was a criteria for being enrolled in the program as a hemoglobin A1C over 8, 50% of them are in range within 6 months. And the average improvement was from 10.6 to 8.6. So they still have some room to go, but that's a major shift in, that metric for that high risk population. Next slide. And if we take a separate case study around hypertension, Same concept, looking at 6 months of data and a cohort of patients with poorly controlled blood pressure who are enrolled in an RPM program. 73% of them are getting into target range within the 6-month period. And you see there sort of the average improvement from 163 over 87 to 131 over 75. So again, whether, all of your payment is tied to, quality measures, or whether you're sort of a hybrid fee for service and quality, this can really help you move the needle on those quality metrics. Next slide. So we spoke briefly, I did, about ease of use. This is just to reiterate how important that is. And there's data to back this up, right? That if you look at the difference of compliance of patients who self-report data, use, Bluetooth or app-based technologies, and use devices with cellular connectivity, that you really get the best engagement and compliance when you reduce the barriers of being successful for that patient. So the less we can ask the patient to do, the more we are setting them up for success. And looking at sort of that patient experience, one question that, I think programs will think about is, are my patients going to continue to want to come see me in the office? Does this replace that office visit? And so this is some survey data looking at patients who had been in an RPM program for 6 months and their answer to that question. So 54% of them said it supplements my face-to-face care. I still want to see my, clinician in person, but it makes that appointment more valuable when I do see them, and maybe I need to see them less frequently. 36% of people said it might replace the need to go see my doctor face-to-face. And I think a lot of this will be consumer preference. And, so many doctors who we speak with are having challenges because of staffing shortages with access, right? At my health system, it takes a year to get a new patient appointment with endocrinology or cardiology. So we've got to put in place more of these modalities that help us take the care to the patient and don't require them to come to the health system every time that they need care. Next slide. And then here's some hard data to sort of talk about that ease of use of those connected devices. So between I find it somewhat easy to use and very easy to use, we have over 90% of patients, and very few patients, only 3%, who find it very difficult to use. So I think that's pretty compelling data that this is, an approachable technology for patients. So to sort of summarize a couple of takeaways about, using RPM and a value-based care model, number one is that the goal of RPM, no matter what model of care you're in, is to improve the management of chronic health conditions. RPM is just a technology tool to achieve that. And so, really focusing a program on those gaps in care or population quality measures that you're looking to impact, and being really clear of what the key performance indicators are on that. Is it something like reducing hemoglobin A1C, or is reducing, ER utilization one of your KPIs that your organization wants to demonstrate, and making sure you set up a program where you're able to capture that data. Second thing is sort of the efficiency aspect of it. And what I mean by that is you have a goal of better managing diabetes in your population. One very effective disease management tactic has been to throw people at the problem. But the problem is nobody has people. Nobody has extra nurses or pharmacists or clinicians who they can dedicate to a program and really sort of man-on-man defense, right? Handhold with that patient, problem solve, and get them get their disease under better control. So finding points of leverage and efficiency are incredibly important. And we've got data to say that programs who had 100, 150 to 1 ratios of case managers to patients, can bump that up to 250 patients per case manager. So right there, it's both a, budget and headcount issue for you that you can do more with less by enabling that team with technology. We talked about the patient experience data. Patients love these programs, and it makes them more loyal to their healthcare provider who offers it, right? Because it really helps them feel supported. The sort of delight that clinicians will tell us of, patients coming in and saying, I've never had you reach out to me before when there was a problem. I've always had to reach out to you, but I enrolled in this remote monitoring program and I got a text message, the first week saying that somebody noticed that, my blood pressure was high and was I okay? And so really turning the tables on patient engagement and not always making the patient come to us, but proactively reaching out to them. And then obviously the long-term goal here is to, reduce complications of these chronic health conditions and thereby reducing the overall cost of care. So next slide. So, having kind of walked through the, considerations and motivations, whether you're in a fee-for-service type model or a value-based care model, and then, I think you've kind of got those takeaways. And then I think stepping back and saying, okay, if you're looking at remote monitoring is something that would benefit your patient population within your healthcare system, who needs to be involved in that process, right? And how do you go about designing a program and finding the right technologies to enable it? One thing is it really does take a diverse group of stakeholders within the health system to design that program, because you're going to need folks from population health, you're going to need IT, and then you're going to need really the clinical stakeholders who represent the end users or the folks who are ultimately accountable for those clinical outcomes. So including them in the beginning of the process, uncovering little pockets that may already be happening in your health system and learning from their experiences with something they may have done at a small scale over the past couple of years, and trying to bring all of that to the table and saying, okay, what's going to work for our population and our health system at scale from a clinical point of view, from an operational point of view, and from a financial point of view. That's where we see organizations really be able to move forward effectively. Many organizations now are going to RFP as they are assessing partners, both technology partners and services partners around remote patient monitoring. And so, sharing here a couple of questions that we think are really helpful in those RFPs. One is, does the partner or vendor only offer technology, or do they actually offer services to support a program? What I mean by that is many systems don't actually have the staffing themselves to run the program they would like to run for remote patient monitoring. They don't, they can't fill the vacancies they have in nursing today, much less dedicate one of their existing staff, either full-time or part-time, to a program like this. So they're looking for a vendor who can help outsource some of that clinical monitoring. And some groups do that, some don't. I think it's a really important thing to ask about and discuss in the RFP process. Asking about the kinds of devices, not just the part I've harped on around how the devices work, cellular versus Bluetooth, but really, why they've chosen the device portfolio they have, what their experience has been with reliability and cost of those devices, and with engagement from the patients where they've deployed those devices. There's also, as I mentioned, everyone trying to get their arms around all these different point solutions. So, how many use cases can a given vendor support for you? And do you have the bandwidth from a project management and program management to support multiple different vendors across individual use cases? Or are you looking for a single vendor to be able to meet your needs across multiple service lines and use cases? Whether or not the technology integrates to the electronic health record and what they really mean by that, right? What's the end user experience of the technology if they say it integrates to the health record? Many of the IT teams care deeply about this integration because it often provides greater cybersecurity and controls for your IT team if the vendor's technology integrates to the health record, because then it's the EHR credentials that are controlling access. They have the ability to, turn on or off access and audit that for end users. So that's a really important question to ask about, and reason to have that IT team involved in the process. And then, ask about references and use cases and outcomes. And, are there people like me, like my health system, using the technology? What have been their outcomes? I think can help you, not only know if they've been successful, but it might help you imagine aspects of the program that you haven't thought about yet. So hearing that sort of peer-based experience is really important. All right, next slide. So, as you, think about that process, for, finding the right kind of technology, designing the right kind of program for your health system, and bringing it all together, right? You want to end up with a workflow where you're coming at it, to, again, focused around those key success measures. Are those clinical indicators, quality measures, patient satisfaction, operational or financial goals that your organization has? And then is the program is implemented, is it set up for success to help you achieve those? Is it bringing together the data from the patient in the home through easy to use devices into your electronic health record workflow, and then creating really efficient experiences by using things like embedded clinical decision support that are highlighting insights and actions to your team, not just aggregating data that they have to sort through. Next slide. All right, so we have gotten through all of the sort of high-level overview, and I would be happy to take questions.
Great, thank you, Dr. Ide. We have a couple of questions here. Let me see. So the first question would be, what percentage of patients qualify for both RPM and CCM?
Great question. So by sort of qualification standards, just to repeat myself on that, RPM patients need one chronic health condition. That was expanded during the pandemic to an acute condition as well, but it's only one, versus CCM, they need 2 chronic health conditions. The truth is, many of the patients who are enrolled in RPM programs for conditions like hypertension, heart failure, diabetes, often have comorbid conditions. So a fairly high percentage of them will qualify for both. You'll find as you implement a program that some patients may be better suited for one than the other. They may not be willing or able to take a measurement with a connected device 16 days out of every month, but really can benefit from the CCM sort of care plan oriented structure of that program. So you can have patients in both, and that can be really beneficial to many patients. But it's great to have a unified approach to both programs so that you can sort of find that happy intersection.
Thank you. Okay, how are other care delivery disruptors, like retail pharmacy, for instance, approaching RPM?
Right, so all of you, I'm sure, have these, kind of consumer-oriented care delivery models in your markets, whether that's coming through the retail sector or, maybe coming through a health plan or employee benefit, and the patients are getting enrolled into a, program for disease management through one of those modalities. The challenges that we hear from clinicians is that suddenly they're, I'm a primary care doc, and my patients being engaged in a blood pressure monitoring program through, an organization who reached out to them and has a virtual care team who may not have all the information about that patient, but is making sort of recommendations and adjustments. And then when they come back to me, there's no continuity there. I don't know what conversations have been had and, what changes might have been made. So I hate to see the aspects where that causes further fragmentation. And I think it's an opportunity for health systems to really lean into that and say, consumers like those programs because they're convenient. So let's offer that level of convenience to our patients, but maintain, streamline care with their existing healthcare provider. So we all need to pay attention to the consumer demand side, and why do people like it? Because it's convenient and cost effective for the patient to not have to take off of work and all these other aspects of seeking medical care. But we're going to see more of it threatening to health systems and practices where these alternate access points are coming in and approaching our patients.
Okay, what have you seen other health systems? How have they approached outsourced monitoring and device management?
We are seeing more and more health systems who need the option of outsourced monitoring support. They need that sort of flex of a nursing team that can help support their program, whether that's just to help them get it started because they don't want to staff it up until they've, successfully built a program, and then they say, okay, now I'm going to hire, 2 full-time individuals or assign 2 people to this program. That's one approach people take that can be effective. Or some of them say, I want to partner with an organization who's going to help monitor these patients so that my staff are doing higher yield things, in the clinic, for instance. So I think that's generally what we're seeing on the outsourced monitoring. On the device connectivity, most groups don't want to be in the device logistics business. So really working with your vendor to, help streamline those logistics of what's best for your patient population. And what I mean by that is it may be best for your patient population for you to enroll them in an RPM program and give them a device right there in the clinic and look them in the eye and say, I'm so happy you're going to participate in this blood pressure management program. I think it will really help you and our staff will support you. Here's your blood pressure cuff. And you can do that part and then actually have, outsourced monitoring help support that, or your staff can support it. But other groups, because of their population dynamics, they want to send that device to the patient at home, and that's fine. That works too. And it alleviates the barrier that you can only enroll patients who you're actually seeing physically in the clinic. So that really depends, on your, demographics of your population, logistics of access to appointments within your system, which one will be right for you.
Great, thank you. So that sums up the questions. And Dr. Wright, I'll let you close it out. I just want to say that we will be sending out a video on demand of this to everybody who joined today, and thank you for your time. If there's anything else you'd like to add, Dr. Wright, please do so.
No, thank you. I just really appreciate everybody's time today. Hopefully this was informative. It is a hot topic that many folks are talking about, and where, it can seem confusing and complicated. So we hope that we shed some light on, various approaches and experiences with RPM.
Great, thank you all.